Okay, so quiz from yesterday. Average was pretty good. Average was about an 86, which is pretty where I want it. So good job there. But we'll go over these questions together, okay? So question number 1, the junctional epithelium plays an important role in the health of the periodontium by attaching to the gingival epithelium to the tooth via hemidesmosome and internal basal lamina. Why is it hemi?
Connective tissue zone.
Two different things, right? Very good. Okay, question number 2. According to the intermittent progression theory, disease occurs sporadically at different rates throughout the mouth. As a result, this theory states that gingivitis will inevitably progress into periodontitis. False. So first part is true, second part is false. Okay. Number 3, on a microscopic level, which of the following periodontal conditions would exhibit extended epithelial ridges, remember holding on for dear life, when evaluating the epithelial connective tissue junction?
C.
It's B and C. So the correct answer would be E. Okay. So basically anything but health, that's when we start to see the ridges forming. Number 4, in health or gingivitis, there is no bone loss, destruction due to disease. Therefore, the crest of alveolar bone should be located approximately where? Yes, apical 2 to 3 millimeters. So the answer is B. Okay. Okay, that is a hand. A bowl-shaped defect in the interdental alveolar bone with bone loss nearly equal on the roots of 2 adjacent teeth is termed what? Osseous crater. Very good. Number 6, while doing your patient's assessments, you notice that the diseased gingiva has bleeding upon probing. This is due to C. So the key word there is the ulcerations within the sulcular epithelium or the sulcus. Good. Number 7, which of the following is a true characteristic of periodontitis? D. Apical migration of the junctional epithelium. So we know that bone is compromised, so it's not intact. Fiber damage is reversible as long as it's periodontal ligament fibers. That's not true, right? And then preservation of all connective tissue attachment. That's not true either, okay? All right, here we have a scenario. Identify the state of the periodontium that best fits the clinical description below. The color, yes. The giveaway there. So yes, fibrotic, very good. And leathery, that pale white color. And then of course we know no JE at apical migration. So we know it's not perio. Good. All right. Question 9, of all the patient records, I'm not going to read this whole thing, it's incidents, right? All the incidents. Number 10, okay. The main cause of perio disease is a combination of presence of bacteria and the host response to such foreign invaders. That's true. Ultimately, attachment loss and destruction of the periodontium is attributed to the host response. That is also true. Number 11, okay, this was our first fill-in, I believe. Okay, of the 3 basic states of the periodontium, identify the state based on its microscopic view, obviously. Periodontitis, okay? So for some of us, I don't know if we didn't read this brief down here, but you were supposed to answer A, B, C, D, okay? So look out for that for the fill-ins to answer specifically what I'm asking for. So if you wrote A, periodontitis, perfect. I even gave you options here, right?
Yeah.
Describe the location of the junctional epithelium, and it even tells you right here, junctional epithelium is pink, okay? But the answer I was looking for was apical to the CEJ, okay? C, because the location of the junctional epithelium, the probe would be touching which tooth structure within the sulcus. If you put root or cementum, I gave it to you, okay? Is the tissue destruction reversible at this point? Hopefully you said no. Irreversible. Good. Refer to this diagram in the previous question to answer, inflammation and bone loss. All right, so what kind of bone loss is depicted? Horizontal. So the answer should have been connective tissue, bone, and then PDL space, okay? Some of us put gingival fibers. That's where you might have seen you got like a half a point, like 0.5. It really should have been connective tissue, okay? PDL space, I gave it to you if you put PDL, all right? What type of perio pocket is associated with horizontal?
Super.
Like your access code, right?
Yeah, thanks for that.
All right. Which one has the worst prognosis?
C.
C. And because it's what type of bony defect?
One wall.
One wall, meaning there's only one wall left. All right, good. All right, that was the quiz. Overall, I thought pretty good. Any questions?
Is it okay that we just put like CT for connective tissue, or do you want us writing it all?
That was fine.
Okay, I was like, we don't have time.
Yeah, I know.
I know, right? Seriously. And then I go back and reread it till next time.
All right, so we're gonna get into our PowerPoint now, but I did want to show you on Canvas, it looks like it is published, so I put resources for APA writing,
Thank you.
and then there's the Al Purdue website, and here's a sample paper. I'll add my PowerPoint to there. I don't think I put that there, but I'll add it, okay? All right, whoever yawns, I feel you.
I know.
Okay, then we have week 4. No, week 3.
Week 3.
There we are.
Wish we week 4.
I know. All right, so you have your PowerPoints. In my announcement, I also asked you to bring your clinic manual, so hopefully you have that with you. And then, if you don't, it's not the end of the world. Don't go running into clinic.
Okay. I was like, I had it yesterday.
I know.
That's what I didn't have. Now I have it. I have it electronic.
There you go.
Is it okay if we have it electronic?
Yeah,
Okay.
totally. Okay, so in addition to your clinic manual, I also recommended that you take a look at a visual aid. This is the AAP classification visual aid. This is just something I made up on my own to kind of guide you guys. But obviously the 2017 AAP workshop would be the official place, but this is just a summary. So it's on Canvas, but if you like hard copies, I do recommend that you print one out if you like to make your own notes and stuff like that. I'll pass this around too, so you guys can read up on that.
That's what I did.
What do you mean?
The library, character library for the reference. Instead of using Purdue or using the reference for our pages. Like if we're doing reference.
You're going to cite this SSC or go to them for help. Yeah, go to them. Yeah. They could be yeah, for sure. Yeah.
Did you say we can print this out somewhere or no?
Yeah, you can print it. It's on Canvas.
It is?
Mhm. Yeah. Okay, does anyone know how to record this? Just in case?
I feel like she wanted to get it.
Oh, I don't think I could. Okay, maybe.
What my,
I have my Canvas. I got something. All right, you guys ready? Ready to go?
Yes.
Okay, so this week, like I said, a really important lecture, actually this week and the next, because this is what your diagnosing is based on. All your case studies for future classes, for board exams, this is what it's going to be based on, okay? So your objectives for today, define and contrast the terms gingival disease, perio disease, and periodontitis. We're going to look at the historical background, how it's changed since this 2017 classification. List, describe, and differentiate various perio diseases according to the current system established by the AAP. All right, so we're looking at chapter 4 here. A lot of you have been pre-reading, very proud of you, so keep that up. That'll help you kind of as a supplemental resource, okay? Okay. So the disease classification system, like any classification system, what we're doing here is just grouping things together, right? So we're going to group healthy characteristics together. We're going to group gingivitis together. We're going to group periodontitis together. By creating this kind of system, that will help us to understand those specific characteristics, and then we can kind of go from there, how to treat the actual periodontal disease. Okay, just so you know, I keep saying 2017, right? Because this is still fairly new, okay? Before then, the last classification system was 1999, so it's been almost a couple decades since they've changed it. Even though they established it in 2017, I want to say it didn't roll out till 2019, so it's still really new. Some offices are still doing case types. Hopefully they catch up soon, right? But 2017 is the latest and the greatest. On your board exam, you are only responsible for 2017, thank God. A few cohorts ago, cohort 21, they had to learn both, which was nuts. I felt so bad for them. But 2017, that's what you guys are responsible for, okay? All right, so this is figure 4.1. I don't expect you to memorize it like this, but I want you to use this kind of as a summary, right? A table to show you how it's broken down, okay? So you have the major headers up top, and then you have your subcategories below it. Right here, I did put a link. It's a pretty lengthy article about how the workshop proceedings were, what the conversations were. It's a really thick document. But if you're interested in that, there's the link there. Okay, so as I mentioned, there are 4 main categories, which are those big headers up above. Perio health and gingival conditions, periodontitis, which we're going to cover those 2 today. And then next week, we're going to look at those other kind of more rare occurrences. So other conditions that affect the periodontium, peri-implantitis, so things that have to do with implants. Okay, so here we are first, periodontal health, gingival disease, and conditions, okay? And as I mentioned, here are the subcategories we need to know. Very first box is going to be perio and gingival health. Then the next 2 are both gingivitis, ultimately. One is going to be plaque-induced, the other one's going to be non-plaque-induced, okay? The verbiage they use is non-dental biofilm-induced, but that just means plaque.
Is that like systemic then?
No. Oh, yes.
Oh,
I'm sorry.
Like, really?
I thought you were talking- yes, so this is plaque-related. This would be other factors like systemic diseases.
Okay.
Could be other things too. Good. This is a little hard to see, but the header is periodontitis. This is going to be our main focus today, okay? We'll also talk about necrotizing perio, which is really cool and really sad, but good to see. And then we're going to look at systemic diseases and its correlation to periodontitis. Okay, next week we're going to be looking at those other conditions. Like I said, these are more of like an add-on, more of a rare case. So we're talking about abscesses, endodontic lesions, deformities, trauma, tooth and prosthesis related factors. So this would be like in combination with the actual diagnosis. And then lastly, we have implants. So everything related to implants, again, this can be very tooth specific. It's not going to be a generalized diagnosis. All right. So just to give you a little bit of background, we're not going to get too into this, but I want to bring it up because, again, some of your offices that you might go to may still diagnose patients as case 0, case 1, case 2, and that's based on the 1999, okay? And maybe you should be like, oh, you need to be more up to date, right? Because it's different now. But also, if you're starting to do research and you see case type 1, case type 2, case type 3, that's also referring to 99 verbiage, okay? So just be aware that it's out there. This, don't worry, this is just FYI, but this is just showing, you know, what it is today and what the equivalent was 1999. So if you come across any of these, you have this available to you, okay? Okay, so in summary, what's the major difference between the 99 system and the 2017 system? For sure, the verbiage. They no longer call it case type 1, case type 2, case type 3. They do staging instead. The other thing is they no longer identify chronic periodontitis as a category, which is interesting. They just took off the word chronic, and they no longer identify aggressive periodontitis as a category, okay? But interestingly enough, you still need to know, like, and we'll talk about it, you still need to know details about it, but just understand it's not its own category anymore, okay? And then lastly, the biggest addition, I think this is why they really came together and reestablished things, was because implants are becoming more and more common, and they didn't know how to speak to it or diagnose it. So they added that whole implant section there. All right, so we're gonna start with health first and then move into gingival diseases or gingivitis. Okay, so our objectives here, we're gonna look at those two subdivisions, plaque-induced, non-plaque-induced, and compare and contrast them. We're gonna describe the clinical signs of inflammation that you expect to see in plaque-induced gingivitis. Then we want to look at systemic factors that will affect that disease. This is pretty important too, medications that cause gingival enlargement associated with gingivitis, and explain how the use of certain medications will modify that disease. All right, so we're starting off here. Okay, so before we get into that, all the gingival disease and periodontal disease, we always start with health, okay? So according to the workshop, their definition of health is basically someone who has no inflammation, right? State free from inflammation, inflammatory perio disease, allowing an individual to function normally and avoid mental or physical consequences due to current or past disease. Okay, so obviously inflammation. We shouldn't see redness, we shouldn't see bleeding, we shouldn't see swelling, okay? And interestingly, according to the 2017 classification system, health can occur on two types of people. This is pretty new compared to 99. So you can be healthy on intact periodontium. What does that mean? No bone loss. And you can also be healthy on reduced periodontium. That's trickier. What do you think that means? Stabilized, very good. So maybe they had bone loss once upon a time. It is now stable, and then they are healthy. Okay. You guys okay here? Okay. All right, so we'll start with intact first. Clinical signs characteristic of perio health with intact periodontium. Obviously no inflammation and everything is still intact. Bone looks really good. You have the crestal bone nice and pointy right there. Really no signs of recession, no bone loss, no inflammation. So this would be your textbook health on intact periodontium. On reduced periodontium, you have two situations. This is where it gets a little tricky, okay? So remember, like you guys said, reduced periodontium, they have bone loss or some type of attachment loss, right? Then we need to figure out where is that bone loss coming from, okay? So the first situation, perio health on reduced periodontium in a non-perio patient, okay? So here we think about someone who brushes really hard, someone who had ortho treatment that moved their teeth too fast, okay? When their teeth move too fast, that causes bone loss, all right? So non-perio patient, meaning, yes, they have bone loss or tissue destruction, but it's not due to disease. It's due to non-disease reasons. Does that make sense? Okay, so here's an example. This is a 54-year-old male patient who has history of excessive home care, okay? He brushes frequently, 5 to 6 times a day. I don't think that's frequent. But he's using a hard bristled brush. That's the main difference. That's the problem, okay? So 5 to 6 days with a hard bristled brush. So probably no plaque or calculus, which is awesome, but check out his teeth, right?
Wore those gums away.
Yes, wore those gums away. And is recession a sign of reduced periodontium?
Yeah.
Absolutely. But in his case, it's not due to disease. He's actually brushing too much and too hard. Okay.
I feel like I still see calculus on slower anteriors.
Possibly. Oh, on the linguals? Yeah. Yeah. A little bit there. Okay. Then we have situation number 2. This is someone who you think of had an SRP in the past, right? They were diseased before. They got their SRP done. They are now good. So this person is health on reduced periodontium on someone who has successfully been treated and now their bone is stable. Okay. Clinical signs of health with pre-existing loss of connective tissue and bone that has been attributed to previous disease. Okay, so this patient successfully treated, now they're good, so now we call them health, but on reduced periodontium. All right, so here's an example. This patient has had NSPT, so maybe they had an SRP, and then they also had surgical therapy in 2016. So they had some surgery to fix some of the bone. 18 months later, signs of health and no progression of disease. So this is an example of someone who's healthy on reduced periodontium. And you guys can see the recession, the bone loss, right? If you look at this x-ray, lots of bone loss here, and then open embrasure spaces, bone loss there as well. All right, so I want you to critically think. This will apply to your treatment planning in clinic. How are you going to scale or treat this person, right? So on each of these scenarios, how would you scale a healthy, intact patient? Prophy, exactly. What would you do for health on reduced periodontium due to non-disease reasons? Tricky, a prophy, okay? Because of the non-disease. And then lastly, how would you scale someone who is now healthy, but their periodontium is reduced and stabilized, and it's because they had disease in the past? Perio maintenance, okay? Does that make sense to everybody? So it has to do with the disease origin and what state they're in at that moment. Yes?
On like the clinic manual for PMs, it says on stabilizing periodontium. So is that like when it's healing after an SRP?
Yes,
Okay.
healing enough. Right, so I'm glad you brought that up. So if you have your clinic manual, if you turn to section 4, page 46. I believe, yeah, page 46. Okay, everyone there? So you should see, it's starting page 46, but I believe, bless you, it goes all the way to 48, and it shows you scaling type, prophylaxis, and who that treats, okay? Okay, so we have a prophy, we'll treat healthy on intact periodontium, healthy on reduced periodontium due to non-disease reasons. And then if you go to page 48, we have our perio maintenance, healthy on stable or stabilizing periodontitis, okay? So that's where we're at right now, and we'll come back to this form in a little bit. Have you guys, I keep bringing this up, but your flow chart in DH20, right? This would be another good resource when you make that visual aid. Okay. All right, so that was it for health. I think pretty straightforward. We have health on intact, we have health on reduced, and then there's the two subcategories for reduced. Now we're gonna move on to gingivitis. So now we're starting to get diseased. Okay, we'll start with plaque-induced first. By definition, this is an inflammatory response of the gingival tissues from bacterial plaque biofilm. Accumulation located at or below the gingival margin. So this was a board's alert where it asked what is the most common form of periodontal disease, and the answer is PI, which stands for what? Plaque-induced gingivitis. So that is actually the most common form according to the 2017 classification system of periodontal disease, which is kind of surprising. So with plaque-induced gingivitis, not the direct cause of tooth loss, but if we don't manage it, it can lead to periodontitis, which we all know. If that's not taken care of, we can lose teeth eventually. The clinical signs and symptoms, it all depends, right? It depends on your age. It depends on local factors, systemic factors. But we need to be aware of kind of everything here. Okay. So it should be noticed that gingivitis is a clinical diagnosis, which is interesting because with periodontitis, what do we need to confirm to make sure it's periodontitis? Radiographs. Gingivitis is the complete opposite, right? If you looked at this x-ray, could you tell me if this patient was healthy or gingivitis? And why not?
You can't see inflammation of the gums.
Exactly. Very good, guys. So no matter if they're healthy or gingivitis, they will always have bone intact. We cannot see gums on x-rays, right? So that is why we say gingivitis is a clinical diagnosis. Does that make sense? Clinical meaning we have to see it with our eyes, and then we double check with x-rays and say, oh yeah, the bone's still intact, so they're just gingivitis, not periodontitis, okay? So radiographs alone cannot be used to diagnose because we don't see any changes in bone. So this could be a healthy patient or a gingivitis patient. And then of course, like I said, you can't see the gums, so we don't know if it's inflamed or not. Okay, when we are looking clinically, right, we're looking like at our gingival description. We want to see those signs of inflammation, the redness, the swelling, you guys know the drill there. But the earliest signs are going to be seen in the papillary region. Where's the papillary region? The little triangle, interdental, meaning in between the teeth. Why do you think that is?
Interproximal is never flossed. by most
Exactly.
patients.
Exactly. It's the most avoided spot. It's the hardest spot to clean, right? So that's why we see early signs of gingivitis in the papillary interproximal region. If it's not taken care of, it then will move to marginal, so along the margin, and then it can become diffuse gingivitis, meaning all parts of the gingiva are affected. Okay, so all parts of the gingiva would include the papilla, the margin, and then all the way up to the attached gingiva. Okay, so important to know what diffuse means. Okay, we touched briefly on this last week, I believe. When we're talking about acute versus chronic, we know acute, it's short, the onset is sudden, whereas chronic is going to be long lasting, and that characterized by usually no pain, and this is usually more common than acute gingivitis. Okay. So this is just an FYI, I wouldn't worry too much about this, but this is just kind of comparing health versus gingivitis and what to see in when it comes to the periodontium. All right, so gingivitis on intact periodontium, okay? Like we said, the radiographs will look fine, okay? But we actually need to look at the clinical picture, our gingival description, to confirm that it's actually gingivitis. In order for it to be diagnosed as PI gingivitis, meaning plaque-induced, plaque needs to be present, right? It's in the name, okay? Okay. We can also have another category where gingivitis can be on reduced periodontium in a non-periodontitis patient. Yeah, Bianca?
I missed the last.
It's okay.
Okay,
Yep. Plaque. All right, good. Okay, so just like we said for health, you can also have gingivitis on reduced periodontium in a non-periodontitis patient. So again, think about your ortho patients, think about your hard brushers, they could still have gingivitis, but the bone loss really isn't due to disease reasons, so non-periodontitis reasons.
Is that something like common in kids?
Not common in kids because most kids still have their periodontium intact.
I
So
see.
common in ortho patients, I'd say, common in aggressive brushers. Mm-hmm.
How do you tell the, like,
He's talking, yeah.
sorry,
Uh-huh.
so if you see the bone loss and you see the signs of gingivitis, how do you know it's that bone loss?
Right, so it's a conversation with the patient. Mm-hmm. So, I know, some will refuse, like, no, I don't have disease, right? It's because I do this. But you have to look at their history. Have they had braces before? Tell me about your home care. What are you using, right? But if there's clearly like a lot of plaque and calculus and they haven't been to the dentist in a few years, then it'd probably be disease reasons, yeah. Mm-hmm.
Is it possible to have like slight vertical bone loss in the molars from grinding?
Yes,
Okay.
yeah. Mm-hmm. If there's like too much occlusal force, totally, yeah. Mm-hmm. Okay, so here's an example. Kind of to answer Kendra's question, right? She was asking, is it common in kids? 17-year-old would probably be a good example. Ortho related, right? He has bone loss, not bone loss, sorry. He has a little bit of recession here, but if you look radiographically, it looks like it's still intact, right? So recession of the gingival margins, that could be due to if he was brushing really aggressively or the ortho was kind of pressing down on the gums. That would be an example there. Okay, on the other end, we can also have gingivitis on a reduced periodontium that is stabilized, okay? So plaque-induced gingivitis after successful treatment, meaning this patient had SRP once upon a time, we put him on a PM, and let's say it's been 5 years. So sure, a little bit of inflammation here and there, but she does not need a full-on SRP, right? That would be your example. So 68-year-old patient previously treated for perio. If we look at her x-rays year to year and it still looks the same, we don't need to SRP her. We would just call it gingivitis on stabilized periodontium. Does that make sense? Okay, I think that's kind of tricky,
Would
but
that person have mobility?
not necessarily. Yeah, this is actually not too bad. When it starts to get down here, yeah. Okay, plaque-induced. Okay, so with gingivitis that is caused by the plaque that's present, other things going on with your body can make it worse, right? These are very important to know. We're gonna go through, I'm gonna kind of zoom in on the really important ones, but this basically means if we have any of these conditions going on, in addition to plaque being present, we're gonna have a worse response, if that makes sense, okay? So localized factors, it could be localized or systemic. We'll start with localized first. These factors will obviously contribute to disease because its presence is collecting more plaque. And we know plaque is the root of the problem, right? So examples can include like faulty restorations, or even if they're not faulty, they're just there and the patient doesn't want to clean it, that can be a modifying factor. Appliances such as retainers, dentures, right? Anatomy or root fractures, and then even hyposalivation can be considered a factor there. Other systemic conditions we'll take a look at: hormonal variations, hyperglycemia, leukemia, smoking, and malnutrition. Okay, we'll start with hormonal variations first. These are the three major ones we want to take a look at, okay? So puberty, menstrual cycle, and pregnancy. I want to add their menopause too. We should probably add menopause to that list also, okay? So these are some of the examples we'll go over. You can see kind of puberty affecting the margins here, and we have a granuloma here, and this is associated with pregnancy, and we'll talk about that. Kind of cool to see, huh? Scary and cool.
Yeah, almost like that.
So why are hormonal variations, why do they play such a big role? So obviously, an increase in the levels of hormones and influx of sex hormone levels will affect the whole body, your host response, and then that will trigger the inflammation in the gums, okay? So what happens due to that increase? The microbiota in the plaque, so the type of bacteria we start to host can be different. Our immune function can be compromised. Vascular properties, so kind of the blood flow of things will maybe increase. Cellular functions of gingiva will change as well. Okay, so we'll start with puberty-associated gingivitis first. So like I said, any of these conditions that fall under plaque-induced, that means that plaque is present, but because we have one of these conditions going on, it's going to be way worse than someone else that has nothing going on, okay? So an exaggerated response to a relatively small amount of plaque. Inflammation usually observed on the facial or buccal side with these teenagers, okay? So it's more so going to be on the facial side. Okay. This is a little controversial, right? I think because now they're finding it's not as common to find these like inflammatory changes in the gums of patients going through their menstrual cycle. But every now and then they say there could be an observable inflammatory change during ovulation. But it's not super like scientifically based. There's not enough research. There's too much variance. This, however, is a pretty big topic for hormonal variation on your boards as well, okay? So pregnancy, okay? Obviously, when a woman is pregnant, lots of different peaks and high levels of various hormones, Levels of estrogen and progesterone continue to rise and reach their peaks in the eighth month of gestation, giving you an exaggerated response to things. It will also trigger an increase of crevicular fluid, so the fluid that seeps from our tissues into the pockets will increase, okay? If we get more crevicular fluid, what's going to be the result, obviously? Inflammation, swelling, okay? So lots of swelling of the gums. Lots of swelling means tenderness, inflammation, okay? What we tend to see as well, increased bleeding while they brush. Typically, it will resolve postpartum, so after they give birth, the hormone levels will start to decrease again, and everything will kind of relax a little bit. All right, so some pathology to be aware of. Again, this is a big boards alert right here. Some cases, the gingival papilla will become so swollen in response to plaque present that they get this pregnancy tumor, okay? Another word for it, pregnancy-associated pyogenic granuloma. So definitely star glitter that one. Pregnancy-associated pyogenic granuloma. This is typically going to be seen for the most part on the maxilla, usually on sextant number 5 somewhere, so anteriorly, and typically during the first trimester of pregnancy. Are you guys good here? Okay. All right, so some things about that granuloma. Usually the patient doesn't really notice. A lot of times, I've seen them usually like around 4 or 5 area, 5, 6 area, and the patient didn't really even notice it was there. They're like, oh, it's a little bump, it doesn't hurt or anything. But if it gets really, really big and starts to interfere like the way they bite down, then that can be obviously problematic. Usually, when you mess with it a little, it will bleed quite a bit, but it should resolve after childbirth. If it doesn't go away, they will just cut it off and get rid of it. It's just extra tissue. Okay. All right, hyperglycemia in plaque-induced gingivitis. So again, we are talking patients who have high levels of blood sugar as well as a little bit of plaque in their mouth, right? If they have a little bit of plaque in their mouth as well as a high blood sugar level, that's where we start to see the inflammatory response going a little crazy, okay? Their home care could be pretty good, but just the fact that there's some plaque around the gingival margin plus this other systemic effect going on, that's why their gingivitis is going to be a little bit more prominent. All right, let's take a break here and then we'll go to systemic conditions.